You guys are in for a real treat today because we're going to talk about some extraordinary treatment options to treat atopic dermatitis, otherwise known as eczema. We're going to talk about all the treatments that are available, but it's important that I give a little bit of a disclosure that I, Dr. Lisa Swanson, has been either a speaker or a consultant for the companies that make the following medicines: Zoryve, Vtama, Opzelura, Eucrisa, Dupixent, Ebglyss, Nemluvio, Rinvoq, and Sabinco. And so we will give you a balanced conversation about all of these choices, but we feel it's important that you know that background information. Hello, everybody, and welcome to another awesome episode of Skincredible. I am Dr. Lisa Swanson, and I'm joined by
Anna,
my helper, my co-host, my EP, my everything.
Aww.
Yeah. So excited to have you here, Miss Anna.
So excited to be with you. I'm honored.
I am so excited for this episode. There's a lot of excitement here.
A lot.
Because we're finally going to start talking about therapies, treatments for the most common condition that certainly I treat in clinic, which is eczema. I would say about 25% of my day is eczema. Talking to a lot of itchy people and their families all day. But it's now a pure joy to be managing eczema because we have so many wonderful ways to treat people.
It's exciting.
Yes.
Tell me what the benefit of seeing you, a pediatric dermatologist, might be over. Like, let's just go to the pediatrician or a dermatologist who's perfectly knowledgeable too. But
of course,
what's the benefit?
I mean, probably the biggest benefit of seeing me is you're going to get a large dose of Bluey when you come to my office. Because
very important.
I have Bluey decorations everywhere. It makes me happy. I pretend it's for the children, but really it's for me. I like to be surrounded by Bluey.
Works.
So that is one special thing about the Dr. Swanson experience.
Very special.
But in general, when you choose pediatric dermatology, you've already gone through a dermatology residency and you're like, I want to see kids. And so you do an additional year of training to be a pediatric dermatologist. And most pediatric dermatologists in the country, they see majority kids, if not exclusively kids, just depending on where they practice. And it gives you that extra level of expertise in managing conditions in kids. Kids are not just little adults. You know, there are additional concerns, both safety and efficacy, and just how you approach a child.
Yeah.
I think there are a lot of clinicians out there that are actually a little bit afraid to treat kids. Yeah. The kids scare them, which I understand. I think when I first started, I was maybe a little bit afraid too.
Yeah.
Like, would I be able to communicate with the little people?
Yeah.
You know? But, you know, the more you do it, the more you love it, the better you get at it, and everything works out. And so I love being a pediatric dermatologist. I would have it no other way. But if you have access to a pediatric dermatologist in your community and you have a kiddo with a skin problem, that's really who you want to see.
Yeah.
Because you are going to have the best experience.
Yeah.
Both from a patient experience dynamic and also from a medical appropriate diagnosis and treatment perspective.
Yeah.
Not that I can't make mistakes.
Of course.
Although it's rare. But if you're seeing somebody that's used to treating kids, knows all the ins and outs of pediatric dermatology, the chance that an erroneous diagnosis or an inappropriate treatment or an unnecessary biopsy be done, I think your chances are definitely lowest when you're seeing a pediatric dermatologist. And so I advocate for my colleagues in peds derm, but I also realize that we are a small field, small but mighty.
Small but mighty,
right? We might not be sharks, but we're baby sharks.
Yeah.
Right?
Do.
Yeah, exactly. And so we have just over 400 pediatric dermatologists in the whole country. 7 states still don't have one.
Wow.
I'm looking at you, Nevada. Nevada is one of the 7. Can you believe that?
No.
You'd think with cities like Las Vegas or
Right.
Reno, you'd think somebody would end up there.
Somebody.
But we have a huge shortage of pediatric dermatologists. We are trying to remedy that. The Society for Pediatric Dermatology is working hard on encouraging dermatology residents to choose pediatric dermatology as a subspecialty so that we can get out there and help all the kids.
Yeah.
But that's a big reason why I wanted to do this podcast.
Yeah.
The shortage of peds derms, the gaps in care and access to care. I'm only one person.
Yeah.
I can only be in one place at a time until AI fixes that.
Yeah.
And I wanted to try to find a way to bridge that gap, get some of my experience, expertise out there for the masses that might live in South Dakota, another state without a pediatric dermatologist.
Sad.
And so I think it inspired me to talk to you to put this together.
Yeah.
And here we are, and we're doing it.
are.
And this episode's really special to me because in years past, up until really past 5 years, 8 years, treating bad atopic dermatitis was really awful. It was no fun at all.
Yeah.
There were a lot of really tough days where I felt that I just could not get things better.
Yeah.
And that was heartbreaking and disappointing and really frustrating.
Yeah.
But now, I mean, you could even say that before we were sleepless in an onyx night, but now our sky is opalite. Those are the lyrics to one of Taylor Swift's newest songs.
I love how you snuck that in.
Right? I mean, it's not hard. Like
Yeah.
everything can revolve around a T Swift lyric.
Probably.
And so that's just the one that immediately popped into my head. And so our sky is opalite when it comes to treating atopic dermatitis. And I'm going to take the audience through this today.
Yeah.
Because this is what I do in clinic every day. What I do, Miss Anna, is I say, eczema is the result of 2 things.
Yeah.
You've got skin barrier dysfunction, you've got immune system hyperactivity. And for the skin barrier dysfunction, it's important to use sensitive skincare products.
Yeah.
And I grab one of my favorite things lists and I check off the sensitive skincare product section.
Yeah.
And then I flip it over and I say, to treat the inflammation, we have these options. And I actually write them out on the back of that sheet of paper.
Yeah.
And I give families the choice. I often tell them, I'm the navigator, you're the captain. It's my job to tell you which options are out there. It's your job to pick which one sounds the best to you.
Good analogy.
Yes. Do some shared decision making is the big clickable term that everybody's using. But it's important. I think it's important for a couple of reasons. Number one, I want patients to feel authority in the care that they receive.
Yeah.
I want them to receive a treatment that's going to be appealing to them, that they will utilize.
Yeah.
I could prescribe anything in the world. If they're not going to use it,
Doesn't
it's
matter.
useless,
Yeah.
right? So something that appeals to them, meets their needs and specifications and desires, something that they'll use and keep up with. And I also want them to know that there are so many options.
Yeah.
It was hard to fit them on this enormous whiteboard. So
It's
many
a big
options,
board,
right? So many options. Sometimes it's a bit overwhelming.
Yeah.
But if we choose one thing today and it doesn't work, no biggie.
Yeah.
Look at all the other things that we have.
Yeah.
And I think that sharing all those choices helps preserve their hope.
Yeah.
That we will find one of these things is going to do a great job. And if we pick one that sounds the best at first and it's not a right fit, well, then we'll try another.
Yeah.
And
I will say, just from working with you too, I think sometimes it can be scary to come to a doctor and feel like something might not be covered by insurance.
Right.
You are one of the just biggest advocates for patients, for parents. You will fight an insurance company. You will fight whoever you need to in order to get something that a patient needs covered,
Oh.
and you feel very passionate about that, which I think
Yes.
is special. And so I think that is also a perk of seeing you, is that no patient left behind in your
Right?
practice.
Yes. Yes. Fight, fight, fight.
Yeah,
Yes.
exactly.
Because, the insurance companies, they say no most of the time.
Yeah.
Because they think I'm going to stop.
Yeah. Little do they know.
Little do they know that only fuels my fire and makes me want it more.
Yes.
They're not helping themselves in any way. And so I turn on my thrusters and I am just like all out attack.
Full force.
Yes. Now I do that because it's important to me and because I'm incredibly stubborn.
Yeah.
And so you tell me no and it's like,
Tenacious.
I'll show you, right? Like I'm going to do this.
Yeah.
It is time consuming for me and for my staff.
Yeah.
The paperwork we have to file.
Of course.
And so I understand and respect that, there are some clinicians out there that maybe don't work as hard at that. I get it.
Yeah.
I get it.
Yeah.
It's a lot of time.
Yeah.
Honestly, if it weren't for my stubbornness and my overall passion for doing what's right, I might give up too sometimes.
Yeah.
I did my dermatology residency at the Mayo Clinic, the world famous Mayo Clinic in Rochester, Minnesota. And the motto of the Mayo Clinic is the best interest of the patient is the only interest to be considered. And even though I don't work at the Mayo Clinic anymore, I take that philosophy with me everywhere I go. And I think what is in the best interest of the patient, then that's what I'm going to get.
Yeah.
That's what I'm going to push for and that's what I'm going to get. And, living and practicing in a state like Idaho, it's a smaller state, smaller population. The insurance companies are also smaller. So sometimes I even get just a teensy bit of a reputation, Miss Anna.
They know you by name.
Just a teensy bit. But I think that's beneficial because I would hope that maybe they don't say no to me as much because
they're like, ooh, this one, you don't want to mess with this one.
Let's let this go through. Let's let this go through. And so patients can be advocates too for themselves. It's just a little bit harder because they might not know exactly the ins and the outs of what the process is and what moves insurance companies and the buzzwords that you need to say.
Yeah.
I do appreciate though, if I'm going through a hard time getting a medication for a patient, I do love it when the patient's family also calls the insurance company and says, hey, what's going on?
Yeah.
That can only be helpful.
Right.
I don't ever put that responsibility solely in the patient's basket.
Sure.
It's frustrating enough for us to deal with it. And we have a staff and we have the knowledge of the ins and the outs of the insurance world. So I don't ever expect them to be handling all of it.
Right.
But a call to the insurance company
never hurts.
I think it never hurts. And I think maybe it can just be like a little bit of an extra push for the insurance company to try to, you find some common ground and see things our way.
Yeah.
Not even common ground, like my ground.
Yeah. But just even like in empathy, to know that a mom is suffering because her kid can't get better, or sometimes those letters of medical necessity and just including pictures sometimes it's just like, this is a real human being. This is not just a piece of paper, coming across your desk. Well, no paper anymore, but
pictures say 1,000 words.
They do.
And a lot of insurance companies are having AI review all these things now. I don't know what it would do with a picture.
No empathy. Does it have empathy?
I don't know.
I don't know.
I don't know. I don't know. There's a lot. I don't know. The world of AI.
Yeah, that'll be interesting.
I know.
See how that changes things. I didn't realize they were already implementing some of that.
And we can too. Sometimes I like to write my own appeal letters.
Yeah, you do.
I was an English major in college and I joke that it prepared me to write strongly worded appeal letters to insurance companies.
You're good at those.
I get some inspirational music playing, like Fight Song by Rachel Platten, or Come in Like a Wrecking Ball, by Miley Cyrus, something that really like pumps me up, maybe Roar by Katy Perry. And I sit down at my computer. I maybe have a couple sips of something caffeinated, and then I just let her rip.
It's happening.
It's like, here's a dose of Lisa. And so I like to write my own.
Yes.
But for busy offices, for busy clinicians, these AI and ChatGPTs of the world can actually come in handy.
Yeah.
The one thing, I was at a conference and they talked about using AI specifically for this purpose.
Yeah.
And they used an example and they asked the AI to find articles about using this drug for this condition in this patient population.
Oh, dear.
And it spit out 3 articles that looked great.
Great.
And then the speaker was like, I read these journals. These articles, I don't feel like I've read these articles. And so he looked at the actual online copies of those journals. There was no such article in there.
They made them up.
Yeah. And so he asked the AI, he said, are these real articles or did you hallucinate? And the AI apologized and said, this is what 3 good articles would look like.
I beg your pardon.
Right? So AI has its limitations.
Take it with a grain of salt. Yeah.
Hallucinations. So take that, and understand all of that. But if you just want maybe even a starting point, like type me up an appeal letter to try to get this for that.
Sure.
At least it gives you a jumping off point.
Yeah.
All
just
the
double check the sources.
Exactly. Yeah. And then you can, insert your additional language and tidbits of information into that.
Yeah.
It can give you a jumping off point. Well, let's talk treatment. Look at this list.
It's long.
I know.
It feels long.
And colorful.
Yeah.
I made it colorful.
It's beautiful.
Yes. I like color, as if you can't tell. Could this green be brighter? I don't think so.
No.
So let's start with topicals. Topicals just means, topical application, creams and ointments and stuff. So we have topical corticosteroids, been around forever, been around since 1950. They're cheap. Yeah. They're effective. They were our mainstay of treatment for decades and decades. They have come under a lot of fire in recent years. Okay. Some appropriate, some maybe a little bit overkill.
Sure.
It's true that if you overuse or abuse topical corticosteroids, that's not great and things can happen.
Sure.
You can get stretch marks, you can get thinning of the skin, you can even get some systemic absorption of the steroid. And so overuse and abuse of topical steroids, that's bad.
Okay.
Appropriate use, using the appropriate strength in the appropriate aged person for, a certain amount of time until everything is clear and then stopping, that can be very safe.
Okay.
And is still a very cheap, cost-effective way to make things better.
Good.
If you are going to go with a topical steroid, they typically come in creams or ointments.
Okay.
Creams rub in completely, but sometimes sting when you put them on. Ointments are goopy like Vaseline. They don't sting, but they're goopy. Mm-hmm. So that's important. Sometimes I'll see kids, they were prescribed an appropriate strength topical corticosteroid, but the first time they used it, it burned and stung like crazy. They weren't able to use it again.
Sure.
And so I commonly ask my patients' families, I tell them the difference between cream or ointment, and I say, which one sounds better to you? In general, the younger a patient is, the more I steer towards ointments because the more vulnerable they are to stinging and burning. The other point to that point, there's an increased incidence of autism spectrum disorder in patients with atopic dermatitis, with eczema. And a lot of patients on the spectrum experience tactile sensitivities.
Yeah.
Where they don't like the way things feel when you put them on. And it's important to hear that, respect that, and create an option list that can be usable for that patient. And so stinging and burning, big deal, especially in the kiddos. Be mindful of that.
Yeah.
Topical steroids, we used to use them quite often in a manner known as the wet dressing. Did you ever hear of that?
I feel like you had to go to places to be wet dressed. No, you put your own wet dressings on. Was it a sock?
Yeah. So there were, in fact, during my residency at Mayo Clinic, we would admit people and wrap them up. And
like
we
a
would
mummy.
Yes, like a mummy. And they'd stay in the hospital for like 2 or 3 days to get clear. So we did sometimes do it in a very organized fashion. Most commonly, people did it at home.
Okay.
They'd apply the topical steroid. It has to be cream with a wet dressing. So they'd apply the topical steroid cream and then a topical emollient cream like a Vanicream or a CeraVe or a Cetaphil. Okay. And then they would put on some damp cotton PJs like long johns, something that would stay kind of close to the skin, and then some dry sweats on top. And they'd stay in that. Some clinicians would have patients sleep in them. I don't like the idea of that. To me, that feels like being on an episode of Naked and Afraid. You know, you're like
cold
and wet.
Yeah.
And so when I recommended them, I told people like keep them on for an hour, hour and a half, like let the kid play around or do whatever and then take them off.
Okay.
We aren't using them as much anymore.
Okay.
Because topical corticosteroids have gotten so much out of favor in general. And because our option list has grown so extensively that we simply don't need to do the wet dressings anymore. The Aron regimen is worth special mention. I wonder how many people listening know about the Aron regimen. So the Aron regimen was created by a dermatologist in the UK named Dr. Aron decades ago.
Okay.
And he somehow got wind of it to a pediatric dermatologist in Chicago who kind of brought it into our sphere in the late 20-teens.
Okay.
But it's a very old thing.
But more newly introduced here.
Yes. And it hasn't gained as much traction as I think it deserves. There are a lot of people out there that kind of poo-poo the Aron regimen, but it is fantastic. It's my favorite way to treat babies and toddlers with really bad face eczema.
Okay.
Favorite. It's safe up to any age, but I find it works best for kids under the age of 8.
Okay.
So if anybody wants to try it, it's safe, but I just feel like the efficacy is greater when they're younger. So what the Aron regimen is, it's a compounded mix that contains 3 ingredients, contains a mild topical steroid, a topical antibiotic, and it's all in a moisturizing base, either cream or ointment. It is super dilute. It's actually 8/9 moisturizer.
Wow.
Yeah, which makes it super safe.
Yeah.
But it also happens to be super effective, like strangely effective given how little medicine is actually in it.
Does it come in gigantic quantities?
It does. It comes, yes, good
Pound?
question. Yes, it comes in a 1/2-pound tub.
Okay.
I used to do the 1-pound tub, but I stopped, and I'll tell you why in a moment. So they mix these 3 things together, and you have the Aron regimen, and it's safe enough and dilute enough that you can use it up to 5 times a day for a bad flare.
Wow.
And then we say taper with improvement. So you might do 5 times a day for like a day.
Sure.
And then like 4 and 3 and 2 and 1. And it's safe enough to use every night at bedtime for prevention and maintenance.
Wow.
So it's something that can be turned up and turned down depending on what kind of day the eczema is having. Eczema is a roller coaster, you know? And so this can bend to whatever the needs are for that patient on that day.
Cool.
And it's safe on any body part. So sometimes we prescribe such complicated routines.
Yeah.
You know, use this mild topical steroid for affected areas on face and folds. Use this topical steroid for affected areas on the body. Use this non-steroid cream twice a day for prevention. Use this topical antibiotic in case it's infected. And remember to moisturize.
Yeah.
You know, that's too much stuff.
So much.
The Aron regimen is all in one. It even, since it's 8/9 moisturizer, it counts as moisturizer in the areas that you're putting it.
Nice.
Yeah. Safe down to any age. Again, it's my favorite choice for babies and toddlers, especially with the really bad cheekies. It has to be compounded, and that can add expense because insurance commonly doesn't cover compounds. It's nothing against the Aron regimen. It's just insurance most commonly has a rule like we don't cover compounds.
Sure.
The cash pay price for a 1/2-pound tub of the Aron regimen at my local compounding pharmacy here in Idaho is $45. So not atrocious. No. So you get a 1/2-pound tub for.
You're going to spend that on moisturizer and steroid anyways.
100%. 100%. I used to prescribe the 1-pound tub initially, but because it's compounded and it's things mixed together, they can separate over time and become less effective. And so people weren't able to like get through it. And then they needed to replace it. I feel like it tends to be effective for about 6 to 9 months after you filled the prescription.
Okay.
And so people were throwing so much of it away.
Sure.
So I started prescribing the 1/2-pound tub. It gives them a chance to actually use it before 6 to 9 months when it isn't as effective. Now, there are some clinicians out there that will say, okay, I know the ingredients in the Aron regimen. I'm just going to prescribe the ingredients separately. And tell the families to mix it together. I call it DIY Aron regimen.
My compounding kitchen.
Yes. It is not the same. It is not nearly as effective.
Interesting.
Because the steroid in it, betamethasone valerate, it comes as a lotion. Mupirocin is the antibiotic. It comes as an ointment. And then you're mixing in a cream or ointment. And so these textures just do not mix well together.
No.
When medicines are compounded by a compounding pharmacy, they're using a powder base of these active ingredients. And so it's able to get so much more easily dispersed throughout.
Yeah.
I understand why clinicians are thinking, oh, I can outsmart this and do my best for patient care and have it covered by insurance. But it's not the same. It's not even worth it, in my opinion.
Yeah.
I would do it compounded or do something else.
Right.
And so Aron regimen comes in real handy for me. Love it a lot. Prescribe it every day.
Awesome.
It has a bit of a social media presence too.
Oh.
So our social media might feel a little bit of that.
Okay.
Elidel and Protopic are what we call topical calcineurin inhibitors. So these came out about 25 years ago, and they are steroid free. There's no steroid in Elidel and Protopic. And they have been useful. The list used to stop there. You know?
Yeah.
We used to have topical steroids. I guess you could throw the Aron regimen in there. And then Elidel and Protopic for 25 years.
Wow.
That's what we had. And so we made them work. They can be very nice for sensitive areas like face and folds where you don't want to be using a topical steroid. We use them a lot for maintenance and prevention. So like clear the spot with the steroid, then switch to the non-steroid. And so we made them work for us. But they're slow. You know, they're slow workers. They have a greater tendency to burn and sting. And they just didn't deliver the kind of efficacy that would allow them to replace or even impinge on the prescribing of topical steroids.
Wasn't there like a weird thing about black box label that people would ask about?
Good question, Anna. So when these medicines came out 25 years ago, the FDA put a box warning on them. The reason for the warning was there's a pill version of these medicines in this family that's given to transplant patients to suppress their immune systems. And so the FDA became concerned that the creams would have the same side effects as the pills and slapped the warning on there. Since then, we've done numerous studies showing that there's no risk for those side effects. But once a warning is placed, it's on there for good. I warn patients and families about the warning, not because it worries me, but because you might read about it and I don't want it to surprise or scare you. And so I do tell everybody about it. But, you know, I think we've hoped for years that that got lifted, but it remains. So next on the list is Eucrisa. And Eucrisa came out in 2017, and it is steroid free, and it is a phosphodiesterase 4 inhibitor, a topical. Whoa. Yeah, I know. Big words, big words. Basically, and I'll tell the audience the different mechanisms of action, but basically what each mechanism of action is doing is it's reducing inflammation in a different way.
Okay.
I mean, that's really the gestalt of it all. It's just decreasing inflammation through various mechanisms. Eucrisa came out in 2017, and we were all so excited. Like, we hadn't had a new medicine since Elidel and Protopic around, 2000, 2002. We hadn't had a new thing for years.
Whoa.
There was a lot of excitement and enthusiasm. And then Eucrisa launched and kind of fell flat on its face.
Shoot.
Turns out it doesn't work very well. And it burns and stings like crazy. In the original Eucrisa trials, they found burning and stinging rates of about 4%. I don't know how they did that because in real life, it's like 30 to 50% of patients. And it's not the sort of burning and stinging that you're like, ooh, that means it's working. You know, and you can like live pain through, right? It's like you have to wipe it off. You're like, this has to go away.
No.
Yeah. And especially when you use it on the face and especially eyelids, just really high burning and stinging. And it made it a very difficult treatment to use. Two advantages of Eucrisa that remain today. It's approved down to the age of 3 months old.
Wow.
It is the only non-steroid approved under the age of 2.
Oh.
So that's something. It's difficult to use because the babies are screaming from the burning and stinging, but it is approved down to the age of 3 months old.
Okay.
Second thing is that it was studied for proactive maintenance use. Basically, they took a bunch of kids and they had them use Eucrisa twice a day, all the time, for prevention and maintenance.
Okay.
And they found that 83% of kids didn't have to go back to daily use of steroids for a year.
Oh.
So I sometimes will use Eucrisa for maintenance.
Okay.
Because if you're applying it for maintenance, that means you're not applying it to actively inflamed skin, and your burning stinging rate will be lower.
Of course.
So it can be somewhat tolerable in those settings.
Okay.
But again, with all the choices that we have now, I honestly can't remember the last time I wrote a prescription for Eucrisa, but it's still there. And I like that it's approved down to 3 months old, and I like the maintenance thing.
Yeah.
Then we have Zoryve. So Zoryve is also a topical phosphodiesterase 4 inhibitor.
Okay.
And so I know what you're thinking. Is this going to be a burning and stinging disaster? No.
Huh.
So Zoryve is a more potent phosphodiesterase 4 inhibitor. And so it is quite effective.
Okay.
And the company that makes Zoryve paid extra special attention to the vehicle. So anytime you have a topical medicine, you have the active and you have the vehicle. The vehicle is what the active rides in, the delivery system. The Amazon Prime truck.
The Amazon Prime.
For your
is that the like
paraphernalia.
ointmenty or like creamy?
So vehicles can be ointment, cream, solution, foam. They can be anything. Zoryve is a cream. And so the company that makes Zoryve paid extra special attention, a lot of time, energy, resources went into the development of the vehicle because they knew that everybody had had this experience with Eucrisa.
They knew about Eucrisa.
They knew.
We gotta do better.
Yes. And they knew that people would have preconceived judgments and feelings because we were all burned, unintended, by the Eucrisa experience. And their efforts paid off because they created a really wonderful, cosmetically elegant cream.
And more effective, it sounds like.
And more effective. And it's just once a day.
Oh.
Yeah.
Nice.
Just once a day at bedtime. There's no benefit to using it more than that. It's just once a day. It's safe to use on any body area. You can use it on your eyelids. You can use it anywhere. It's safe to use as prevention and maintenance. So in the Zoryve trials, once patients were clear, they had them use it twice a week for prevention and maintenance. And they found that 57% of them didn't have to go back to daily use for a year.
That's pretty good.
So that's pretty good.
Yeah.
So I tell patients that I see that they can use Zoryve in a proactive way, where they're doing it twice a week for prevention, or a reactive way where they're just treating flares. Like either way is totally fine.
Cool.
There's also no limitation with Zoryve on combining it with any of our systemic agents that we'll talk about.
Nice.
And no limitation on the amount that you can apply, the body surface area that you can apply it to.
Okay.
I like Zoryve. It might not like blow your socks off initially, but it is a very consistent, steady, durable cream. Yeah.
Okay.
Yeah.
Like good husbands sometimes.
Yeah. Or like, I just thought of like the little engine that could. Vtama. Vtama, get ready for this, is an aryl hydrocarbon receptor modulator.
Whoa.
What? I know. It's the only one of its kind. There are no other aryl hydrocarbon receptor modulators. Vtama is the only one. It's approved to treat atopic dermatitis eczema down to the age of 2.
Oh.
And actually, let me back up just for a moment. Zoryve is also approved down to 2.
Oh.
So we're loving that.
Yeah.
That change happened recently. Zoryve was previously 6 and up.
Wow.
It recently
That's
went
a
down
big
to
jump.
2. Yeah.
Cool.
And so
who names these? I'm sorry.
I know. I think it would be kind of funny to like be on that committee.
Yeah.
And just like you feel like the wizard, you're like, and we shall call it this.
Yes.
And then that's its name. No matter how weird it is. Right?
I was just waiting for the moment you were going to pronounce this.
Yes. Yeah. You're like, how?
It's missing a letter.
Yeah, right. Shouldn't there be a
vowel?
vowel there? Yeah. So Vtama, aryl hydrocarbon receptor modulator, beautiful origin story for Vtama, Anna. It is naturally derived.
Oh.
Naturally derived.
Mildly earthy?
Mildly earthy, you could say. You could say mildly earthy.
Wow.
It is based on a metabolite that is found in the guts of worms to maintain homeostasis in the worm.
Whoa.
Right?
How do we learn this stuff?
I
Do we
know.
just open a little worm up?
Right? Like who was like, this worm poop,
Yeah.
I think it's got something.
It's good.
We need to look more into worm poop,
Yeah.
But whoever did, we're grateful for it because now we have Vtama. It also is once a day. at bedtime.
Convenient.
It also has no restrictions on body surface area that you can use it.
Okay.
It also has no restrictions on combination therapy with one of the systemics.
Nice.
It has one side effect. About 10% of patients will develop these little follicle bumps, these little bumpies.
Okay.
They don't hurt or itch. They go away if you stop using the cream. Nobody quit the trial as a result. And so more of a nuisance concern than a serious concern.
Sure. On your face too, or?
Anywhere you put it.
Okay.
Except for palms and soles.
Because there's no follicles.
Because there's no follicles.
Okay.
And it's actually a wonderful treatment for hands and feet. It really seems to have a bit of a niche for hands and feet. And I love it for like 2 or 3-year-old kids that have eczema on their hands and they're constantly putting their hands in their mouth because it actually cannot be orally absorbed.
Whoa.
It cannot be orally absorbed. And in the studies, the FDA mandates certain studies to ensure safety. And so they have to give the medicine in like huge doses to, rats or mice or whatever to try to see like what happens if you just drank a whole bunch of it. They could not drive systemic absorption of the Vtama.
Whoa.
So that's nice.
Yeah.
Yeah. Yeah.
Right.
Because the kids, their hands are constantly.
Sure.
And this we know is okay.
Nice.
And then the other thing about Vtama, I have noticed in my practice that Vtama either works amazing, like hitting a home run, or it doesn't work at all.
Oh.
It's like a strikeout. Nobody hits a double with Vtama. It's either the best thing they've ever used or nothing happens.
Okay.
And then Opzelura. Opzelura is a blockbuster. It really is. It came out 4 years ago and was originally approved age 12 and up. It's approved to treat eczema. It's also approved to treat vitiligo. And then just recently, in October of 2025, Opzelura got its age indication down to 2.
That's like a 10-year gap?
Yes.
Whoa.
Huge.
Yeah.
Huge. Opzelura is very special for a variety of reasons.
Okay.
Number one, super effective.
Nice.
Super effective. It has the efficacy and speed of improvement of a topical steroid without being a steroid.
Nice.
It's really great. Really rapid efficacy, especially when it comes to itch. They have data showing that it improves itch symptoms as early as 15 minutes after application.
Whoa,
yeah, 15
minutes?
Yeah. And so sometimes I like to say it's as fast as a greyhound because there's an episode of Bluey called Obstacle Course.
Okay.
Where Bluey and her dad are racing in an obstacle course and her dad wins. And then Bluey wants to train to beat her dad in the obstacle course. And her mom is helping her.
Aww.
And to pump her up, she says, "How fast can you run?" And Bluey says, "As fast as a greyhound." And her mom says, "How fast are you gonna run?" And she says, "As fast as a greyhound."
Cute.
Yes, it's so cute. And so Opzelura is as fast as a greyhound, particularly for itch. It does not burn and sting.
Nice.
Does not burn and sting. It's my favorite choice for patients with tactile sensitivities for that reason.
Nice.
And so,
is it the same kind of long fancy name that you gave the other one?
Its mechanism of action?
Yeah.
Thank you for bringing me to that.
Yes.
So it is a topical JAK inhibitor.
Oh, I've heard about these.
Yes. So JAK inhibitors are a family of medicines. Opzelura is a topical JAK inhibitor.
Okay.
And that's important because there are a couple special things about JAK inhibitors and about Opzelura. So number one, Opzelura is approved to treat up to 20% body surface area at a time for eczema. It's 10% for vitiligo, 20% for eczema.
You're not slathering it all over.
You can't slather it all over. And the size of my hand is 1% of my body surface area. The size of your hand is 1% of your body surface area. The size of a 2-year-old's hand is 1% of their body surface area. Oh. And so you can apply the cream to up to 20 hands of areas at a time. Second thing that's special. So JAK inhibitors, most of the members of the family are pills. And because of a member of the family that is a pill and a study that was done on it, it's a medicine called Xeljanz, the FDA thought it prudent to put a safety warning on all JAK inhibitors, the entire family.
Here we go again.
Exactly. Including our little Opzelura. And the way I like to say it, Opzelura is a lot like Kendall Jenner. She's low drama. but she's in the same family as Kim and Chloe and Courtney and Kylie. Higher drama. Higher drama.
Okay.
Yes. But Opzelura is safe to apply anywhere. It's also the only topical on the list, maybe besides the Aron regimen in like a baby or a 2-year-old, where you can have a patient that has moderate atopic dermatitis and therefore is a candidate to go on a shot or a pill.
Okay.
And as long as they don't have more than 20% body surface area involved, Opzelura can keep them in the topical world and they don't need to go on to a shot or a pill.
Which is nice.
Which is nice.
Yeah.
I'm a big fan of these shots and pills. We're going to talk about them. Huge fan. World's changed, like wonderful. But if a patient can get by without the ouch factor of a shot or without needing to have their blood drawn, that is a really cool big deal to me. Opzelura is capable of that. In fact, they looked at a prescription claims database. They looked at patients who had filled a prescription for Opzelura for their atopic dermatitis, and they followed their prescription habits for the following year. 91% of the patients didn't progress to a shot or a pill.
Nice.
91%.
That's amazing.
So I think that's something really special about Opzelura. One limitation for Opzelura, you're not supposed to combine it with any of the systemics.
Okay.
And that's a big bummer. And it's just because, it was something issued as a limitation of use because it hasn't been studied in combination. And out of an abundance of caution because Opzelura is a topical JAK inhibitor. And so I understand it, but it's kind of a bummer because I think the combination of one of the shots, one of the biologics we're going to talk about, and Opzelura can really be a dynamic duo for patients. Which brings us nicely to shots.
Yay.
Yes. Injectables.
Well, not yay for everybody. It hurts a little.
But yay for the benefit.
Yes.
Yay for the joy provided by the pain.
That's right.
So Dupixent. Dupixent was the first one. It came out in 2018.
Okay.
So we have had almost 8 years of experience with Dupixent. And it revolutionized the care of atopic dermatitis.
I remember when it first came out.
Yes.
Wild.
Big deal.
Yeah.
I think of my career as BD before Dupixent and AD after Dupixent because it so completely changed the way we practice and the way we care for patients with atopic dermatitis. I become a bit known for saying that picking a systemic agent to treat bad atopic dermatitis before we had Dupixent was like picking a porta potty out of a row of porta potties. They're all going to suck, but you got to pick one when you have to go.
Just go for it.
I was never excited to put a patient on methotrexate, cyclosporin. These are systemic immunosuppressants with some real risks. And now we don't have to pick a porta potty anymore.
That's awesome.
I know. So Dupixent is a shot. The exact dose is based on a patient's age and weight, but it's either every 2 weeks or every 4 weeks, depending on age and weight. It is also approved to treat so many other conditions, and there's a lot of overlap. So it's approved to treat asthma.
Nice.
It's approved to treat EOE, eosinophilic esophagitis. And so if I have the opportunity to treat a patient with 2 conditions with one medicine, feed 2 birds with one scone, if you will. We're not killing birds with stones.
We're not killing. We are feeding with scones.
Feeding birds with scones.
Okay.
PETA,
I like this better.
PETA approved. Then that seems very appealing. If I can treat their asthma and their eczema and their EOE, let's do that all in one fell swoop.
Is the dosing different?
The dosing is different. Well, the dosing is the same for the indications. The dose just varies based on age and weight.
Oh, gotcha.
So the dose for asthma in a 6-year-old is the same dose as eczema in a 6-year-old.
Okay. So if you happen to be treating your asthma, it might just treat your eczema if you happen to have it also.
Exactly.
On the same dose.
Exactly. Dupixent is remarkably effective, remarkably safe. The most common side effect is conjunctivitis. I find that it happens less in the kids than it does in the adults. And it's like an eye redness.
No, not the same as
No,
pink
but
eye.
it could look like pink eye.
Okay.
It could look like pink eye to the casual observer.
Sure.
And most of the time we can manage that. We'll do some eye drops and stuff. I've only had one patient since Dupixent came out that had to stop the medicine because of the conjunctivitis.
Okay.
So normally it's a very manageable thing. On Dupixent, it's not a steroid. It's not an immunosuppressant. There's no need for blood work on Dupixent. It's approved all the way down to the age of 6 months old.
Whoa,
6 months old. We give it to babies.
Amazing.
Yes. Because Dupixent has been around for so long, we have some really wonderful data about how it affects the disease trajectory and comorbidities of atopic dermatitis.
That's wonderful.
So we have data showing that babies and kids, young kids started on Dupixent for their eczema. It lowers their risk of asthma and food allergy.
Whoa.
So we can thwart the atopic triad, now quadrad. We can prevent these things.
That's cool.
By treating kids early who have bad eczema, who we would predict have an increased risk of having these comorbidities.
Yeah.
We can actually reduce that risk for them. We have data on Dupixent showing that it helps ADHD.
Wow.
So we know that patients with bad atopic dermatitis have higher rates of ADHD. One study in the peds derm literature points to a potential reason for this being the effect of excess IL-4 on a developing brain in a kiddo. So IL-4 is one of the crucial cytokines in eczema. IL-4 and IL-13 are two of the biggest players. Dupixent works to target both IL-4 and IL-13.
What's a crucial cytokine?
Oh, good question. So a cytokine is kind of like an inflammatory messenger. It is trying to activate the immune system. It is creating inflammation.
Okay.
Yes. And so IL-4 and IL-13 play a pivotal role in eczema. Dupixent works to target them. In mouse models, they found in the atmosphere of excess IL-4 decreased cognition, developmental delay in the mice. And so we think this might be the connection. Now we have Dupixent, which works to inhibit IL-4.
Yeah.
Can that affect things like ADHD?
Yeah.
Yes, it can.
Wow.
So there was a study where they looked at the use of ADHD meds in patients who were started on Dupixent for their eczema before they were started on Dupixent and after. And they found a marked reduction in the need for ADHD meds once started on Dupixent.
Impressive.
Very impressive. Lastly, growth. So growth is a big deal when it comes to eczema in kids.
Yeah.
Kids with eczema tend to be smaller on growth curves for height. We wondered why. It's due to poor sleep. And so if we could treat the eczema so completely that then kids were sleeping better, could we mitigate that? Yes, we can.
Wow.
So Dupixent did a study, a 4-month study, Dupixent versus placebo in kids aged 6 to 11 years old. And they found that a third of the patients on Dupixent grew more than 5 percentiles in 4 months compared to 10% on placebo.
Sheesh.
Yes. So, and they found increased levels of bone growth biomarkers in the blood of the patients on Dupixent.
That's cool.
So Dupixent can help kids grow. And I have found that talking about growth moves the needle, pun intended, better than talking about any other comorbidity of eczema. I joke that it has become quite clear to me that nobody wants a short child, which I try not to take offense to.
Don't think about it.
As I sit here proudly at 5'1.5", you know?
And a half.
But a half is important.
Yes, it is.
But you know, I talk to families and parents about the impact on growth, and I really have their attention.
Yeah.
Because they don't have any idea that eczema could have an impact on something like that.
I didn't.
Yes. And so Dupy, wonderful, changed the world. The only downside, literally the only downside, the shots hurt.
Yeah.
They hurt. The way I like to frame it when I'm talking to patients and their families, I don't sugarcoat the fact that it hurts.
Yeah.
But I emphasize the positive.
Yeah.
It turns the eczema into something that you're thinking about once or twice a month rather than every single day all the time.
Yeah.
That 5 seconds of ouch is worth feeling better all the other seconds of all the other days.
Yeah.
So that's how I kind of frame it. I had a patient recently, a little 9-year-old, who had really bad eczema. And we were talking about Dupy, and she was a hard pass when the conversation started. Hard pass on Dupy. And as we're talking and we're talking and we're talking, it turns out she cries herself to sleep every night because her skin hurts, it itches, she's uncomfortable, she doesn't like it.
That breaks my heart.
Right? And I said to her, I don't know about you, I'd rather cry once a month than every night. And so at the end of the visit, she agreed to start Dupixent, did wonderfully. So I think it's all about framing it.
Yeah.
The shot hurts.
Yeah.
But it's worth it.
Do you still offer, like, you teach the patients, you maybe have them come in for the first few?
Yeah. So the shots can be given at home or in the office, whatever families are comfortable with.
Okay.
At our office, we do allow people to come in to get their shots. Not every office is staffed and equipped for that.
Sure.
So I don't want to broadly, say,
we're going to promise it for everybody.
Your local dermatologist will definitely do the shots in the office. I know some facilities just don't have the space or the staff for that.
Yeah.
But at my office, we will let them come in and get the shot there, at least until they're comfortable.
Sure.
Usually families, even if they're nervous at first and they'll come in for the shots, then eventually I think they get sick of taking the time to come in and they're like, okay, we'll learn this. And there are different techniques to try to get through it the best way you can. I find that the Dupixent comes as either a pen or a syringe. Utilizing the pen and injecting in the tummy is a technique that I utilize a lot in kids. I also do something called the HELP method because Dupixent's going to help them. Mm-hmm. So the H stands for hug, the E stands for electronic device, the L stands for lollipop, the P stands for prize.
Cute.
And so we get the kiddo undressed. We have something good playing on an electronic device. We put a lollipop in their mouth. And then we have the parents sit in the chair with the child in their lap facing them in a hug.
Aww.
So you can give it in the arm or the thigh. You have 4 convenient sites to choose from.
Yeah.
And then it's just go time and you get it over with. And then it's clap, 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 prize box. Because the kids are going to cry because it does hurt.
Yeah.
But they recover so quickly. One comment about Dupixent with regards to vaccinations. So per label, non-live vaccines, which is the majority of vaccinations, are safe to receive and there's no worries. It's actually been studied.
Okay.
Live vaccines per label are to be avoided. And the 2 most common live vaccines are MMR and chickenpox. And those are typically given between the ages of 1 and 2 and again between the ages of 4 and 5.
Okay.
So those are the windows of time where this needs to be on a family's radar or pediatrician's radar or dermatologist's radar.
Sure.
In the past, we would have people take a little bit of a break. Like we'd have them take their Dupixent and then wait a month, get the vaccinations, wait a month, restart Dupixent.
Yeah.
But now we're having growing evidence from our allergy colleagues that maybe we don't even need to worry about this at all. So I've become much more calm about that potential thing.
Yeah.
I think that's important because I think it's important to not stand in the way of appropriate vaccination for youngsters. Going down our list of some additional shots. So we have Ebglyss and Adbry. I mentioned that Dupixent inhibits IL-4 and IL-13.
Yeah.
Ebglyss and Adbry work in a selective way on IL-13.
Okay.
And Ebglyss in particular has a high binding affinity and a slow dissociation rate for the IL-13. So it's really powerful towards IL-13. And IL-13 is probably the more important player between IL-13 and IL-4. Huge debate about that in the dermatology world, but probably IL-13 is more important. And I'll focus mostly on Ebglyss. Adbry came out first, but in my view doesn't have as much of an advantage as Ebglyss does. Ebglyss has efficacy similar to Dupi.
Okay.
Safety similar to Dupi.
Okay.
With 2 big differences. Number 1, their SHOT hurts less. I always spell the word shot in clinic. If Dupixent hurts at a 10 out of 10, Ebglyss is a 6-7. 6-7. I joke. And I'm doing the motions for those of you that are listening. I joke, but it is true. Like it does hurt a bit less than the Dupixent shot.
Interesting.
And once you've had success on Ebglyss after 4 months or so, you can do a monthly shot instead of an every 2-week shot.
Oh.
Now, Ebglyss and Adbry are approved down to the age of 12.
Okay.
Dupixent's down to the age of 6 months old. Ebglyss and Adbry down to 12.
Okay.
And then Nemluvio. Nemluvio is a biologic. All these shots are what we call biologics. But Nemluvio works in a different way from the others. Okay. It's an IL-31 inhibitor. I know. I'm throwing a new cytokine at you. Yes. So IL-31 is known as the master itch cytokine. So Nemluvio is testing the theory that eczema is the itch that rashes. And if you fix the itch, you'll fix the eczema. What we see in the Nemluvio data is remarkably fast improvement in itch. Like within 2 days of getting your first SHOT, you are far less itchy. So super fast, greyhound fast, itch improvement. It takes the skin a bit longer to clear in terms of the skin lesions and stuff.
Yeah.
But a lot of patients are able to be patient for that because it's the itch that's the biggest burden. And a lot of times with Nemluvio, we're using topicals too to try to kind of augment that.
Okay.
Nemluvio is also very safe.
Good.
It does not have the conjunctivitis side effect, which has been reported with Dupixent and Ebglyss and Adbry. It doesn't have conjunctivitis. Sometimes it'll even create like a little bit of a different rash, like urticaria or like kind of eczema-like, but not entirely eczema.
Okay.
So sometimes it does a little bit of that. But
Interesting.
overall, very well tolerated, excellent safety profile, no blood work needed, doesn't suppress the immune system. One of the coolest things about Nemluvio is that the shot is painless.
How?
I know. The shot is painless. And it's because it's a much lower volume than Dupixent and Ebglyss and Adbry. It's 0.49 milliliters. And the liquid itself is super thin.
Oh.
It's actually been a little bit of a problem because people will be injecting themselves and they're using the pen device and they're injecting themselves and they don't feel it. And they're like, is it working?
Oh, no.
And then they lift it up and the medicine
Spill the
goes
mess.
everywhere. Yes. And so, but it's approved age 12 and up. And for the patient who's 12 and up, who doesn't want to take a pill, doesn't want to have blood work done, because we'll talk about that, but is afraid of shots,
Okay.
Nemluvio is a nice choice. And lastly, our pills. So Rinvoq and Cibinqo are 2 oral JAK inhibitors, both approved for the treatment of eczema, both approved age 12 and up.
Okay.
And these oral JAK inhibitors are remarkably fast and remarkably effective. Rinvoq even did a head-to-head study versus Dupixent and was shown to be more effective than Dupixent. And Dupixent is an awesome medication.
But 6 months to 12 years is a big gap.
Yes.
Of patients
right.
who have eczema.
Exactly.
Yeah.
Now, studies in the pediatric space for Rinvoq have begun.
Okay.
We're enthusiastic about that. There is even a liquid already available of Rinvoq because it is approved down to the age of 2 for juvenile arthritis.
Oh.
And so it's been studied in the pediatric space, but not yet approved for eczema in the pediatric space.
Okay.
But we're patient and we're excited for it. These medicines offer robust efficacy that is super, super fast, especially when it comes to itch. Really life-changing capabilities with these medicines.
And no SHOT.
And no SHOT. I tell families these are wonderful medicines with an unrivaled ability to truly change lives, but they have a little bit of safety baggage that I can sum up in 3 points.
Okay.
Number 1, we do have to do labs. There's some blood work involved. Number 2, there is an increased risk of cold sore virus and shingles. And so I ask if they have had a history of cold sores, if they're older patients, have they been vaccinated for shingles? I think that's important. Number 3, there's a safety warning on all JAK inhibitors that stems from a study on a different JAK inhibitor called Xeljanz being studied for a different disease state, rheumatoid arthritis, in a different patient population, folks who were older than 50 with a 1 cardiovascular risk factor. They were all on methotrexate and 57% were on prednisone.
Oh.
Yeah. And because of safety concerns in that study, the FDA thought it prudent to put the safety warning on all JAK inhibitors.
Even though these people aren't on prednisone or methotrexate, which is very different.
Yes.
Wild.
And we have not seen those same safety signals in our eczema patients on Rinvoq or Cibinqo.
Okay.
But it's important for patients to know. Yes. And Rinvoq and Cibinqo are approved age 12 and up. They're each a once-a-day pill. They come in 2 doses. You start with the lower dose and you can accelerate to the higher dose if you need it. Okay. But what an amazing thing, an amazing world to live in. Yes. And I have had the privilege to treat patients with all of these medicines, each and every one of these medicines.
Yeah.
and see the positive benefits. I mean, it's wonderful. It's almost like medicine for me. Like my life as a doctor has been made better. Because of these medicines for my patients. And that's a wonderful thing. We're living in the golden era.
Everybody shines.
I know.
Yeah.
We give them their sparkle back.
Yeah.
Don't let anybody take away your sparkle.
No.
And sometimes eczema can take away somebody's sparkle.
Yeah.
Yes.
It's true.
And so thrilled to have all of these. There's a patient for each and every one of these options. It's wonderful to have so many choices, and there's more on the way. And what we'll try to do with this podcast is, as new therapies come out, as they launch, we'll have a special edition episode.
Love it.
To catch people up on what's new.
And we'll make sure to include the names in the description since nobody can spell them.
Right. Yes.
Or pronounce them.
Yes. Actually, kind of funny thing. When I'm giving talks about Ebglyss, I commonly say, you guys, this name's going to grow on us. I know it. It's going to grow on us. I think the thing that is weird about it is the B and the G next to each other. Right. And so when it first came out, I did what I thought was a pretty thorough and exhaustive search of if there are any words in the English language that put a B and a G next to each other. And after spending probably more time than I should have on this project, I concluded that no, there were no other words in the English language that put a B and a G next to each other. And so when I first talked about Ebglyss, I declared proudly that this was the first word in the English language that put a B and a G next to each other. And after I was done, I was like, any questions? And somebody in the audience said, actually, you forgot crabgrass and subgaleal.
Oh, God. The top of their head?
Clearly they were searching while I was talking. And so I was like, okay, correction. This is the third word in the English language that put a B and a G next to each other. Still remarkable.
That is so funny.
I know. And so we've learned, I hope everybody has learned so much.
I have.
I hope it's really empowered people to seek out one or several of these treatments that they heard about now and it sounds appealing to them, because nobody needs to suffer with eczema anymore. Nobody should be suffering with eczema anymore.
I have some people I'm going to send this podcast episode to.
Yes.
They need to hear it.
Yes.
They could be better.
Right.
Faster.
Better, faster, safer. I mean, we just have the wonderful ability to truly change lives with these medicines. And it's a wonderful time to be practicing medicine and practicing dermatology. And I hope you guys have enjoyed getting this kind of window into the field, the wonderful world of treating eczema. And we've just begun. You guys are going to hear true patient stories from patients who have been on these medicines.
Don't miss it. Patients just like you and I.
Patients just like you and I that have a story to tell. Stories are the best.
Yeah.
They're the best. That's what really tugs at our heartstrings.
It does.
And so thank you so much for tuning in. Can't wait to tell you more stories about eczema and about other dermatologic conditions. There's so much to talk about, you guys. Have a wonderful day. Thanks for tuning in.